म मेरो प्रेजेन्टेसन हजुरलाई गर्छु है। गुड इभिनिङ सर, myself Dharmendra Poddar, currently studying at Janaki Medical College and Teaching Hospitals. I am third year medical student. I am going to present the clinical case on valvular heart disease. May I proceed, sir?
Yes, sure.
First of all, I would like to start with patient particular. 58 years old, male, married, Ramlakhan Mahatto, Hindu by religions, businessman by occupations, an inhabitant of Mahendranagar 5 Dhanusa, was admitted to the emergency department of Janaki Medical College and Teaching Hospitals on 8th March 2077 with the chief complaint of difficulty in breathing since 3 months, easy fatigability for 3 months, palpitations for 1 month, and swelling of both lower limbs for 1 week. Now I would like to present with history of present illness.
Okay. Just a minute, okay?
Yes.
Let's try to make it a little bit of fun, not only like any stereotypical pattern. Okay, so can you go to the previous slide?
Yes, sir.
Okay then. So it's about learning, teaching and all, so don't be worried about too much. I mean, what questions I'm gonna face and all those kind of things. So let's try to make it a bit of fun, okay?
Yes, sir.
And one thing I would like to express is medicine is a bit of a fun and a lot of logic as well, okay? And one other thing is you should not always be focused on what is the diagnosis and all those things. So let's try to keep our options very much open. And from here itself, so from this slide, so what will be your differential diagnosis? Maybe you had not expected this question, but don't worry about it, okay? So go on. So someone who comes with difficulty in breathing for 3 months, easy fatigability for 3 months, palpitation for 1 month, and then bilateral lower limb swelling for 1 week, right? So what comes to your mind?
First, sorry, it might be the case of Mitral stenosis.
Okay. Let's make it a little more easier, okay? So what system do you think could be involved?
Sir, it's likely cardiovascular system must be involved.
Okay, one is cardiovascular system, right? Okay, any specific reason for that?
Here is palpitations for 1 month.
Yes, so palpitations, easy fatigue and difficulty breathing all are like cardinal features related to the cardiovascular system, right?
Yes, sir.
Good. So what other system?
And most likely respiratory system also involved in this chief complaint.
Yeah. All right, so in respiratory system involvement also, if there's a disease with the respiratory system, you can have difficulty breathing, you can have fatigue, you can have palpitations as well, plus swelling as well, isn't it? That is
Yes,
absolutely possible, right? So any other system? Okay, so we think that at this point of time, most likely respiratory system or cardiovascular system is the culprit.
Yes, sir.
Right? Okay, so later on we will find out whether this is basically hypothesis, right? We're trying to make a hypothesis that okay, maybe it's related to CBS or it's a respiratory involvement, isn't it?
Yes.
Okay. So there might be some other like system involvement also that we will talk about later. Okay, but so for now, let's go on to history of presenting illness.
Okay, sir.
Yeah, you can proceed.
Yes, sir. Thank you, sir. HOPI, history of present illness. According to the patient statement, he was apparently asymptomatic, performing his daily activities 3 months back. Then he suddenly started noticing shortness of breath while uplift 3 flights of stair, which was previously able to climb, which was insidious in onset, increase on exertion, gradually increasing nature, and reduce on taking rest and sleep. The symptoms was gradually progressive such that since 2 months, the patient has frequent episode of feeling breathlessness during sleep, which began about 2 hours after sleep and relieved on sitting and deep breath. For the above complaint, patient was taken to the hospital 2 months ago and was told to have a heart disease, may require surgery, and was given oral medications, following which the patient felt symptomatically better and was able to perform his daily routine with improvement in his sleep pattern. Next, the breathlessness further progressed to the current state such that patient feel breathlessness even on sitting in the bed and wasn't immediately after lying in supine positions with no relief with medications. He also complained of easy fatiguability since 3 months after exertion for some durations, which is progressively worsening. Two, he noticed palpitations since 1 month, which is insidious on onset, progressive in nature, such that patient experienced palpitation initially on exertion lasting about 8 to 10 minutes, which is regular in nature, relief on taking rest and oral medications. But currently he feel regular palpitations even during rest, which is felt sometimes during sleep since past 2 weeks. He also developed both leg swellings since 1 week. Swelling was painless. The patient noticed swelling up to mid calf, which reduced partially on limb elevation. Occasionally, he had cough strained with blood for 2 months, which was productive, with no seasonal variations and not exacerbations after postural change. With this above complaint, he visited to Janaki Medical College and Teaching Hospital and get admitted in the ward for further treatment on 8th of March 2077. In negative history, he has no history of chest pain, he has no history of syncopes, he has no history of fever, abdominal pain, faces edema, hoarseness of voice, or any discoloration of the body. Sorry.
So that's the history of presenting illness, right?
Yes, sir. Yes, I have completed, sir.
So I think so. Let's finish with all the history, and then we'll come back
Okay,
with
sir.
all the. Do you have any like differential diagnosis at the end of history of presenting illness, or you want to do it at the end of history itself?
Sir, I have prepared differential diagnosis after my HOPI, sir. History present illness.
After your HOPI, okay, fine. After like this history of presenting illness, does your hypothesis change a lot? Do you still feel this is cardiovascular or respiratory, or which one more likely, cardiovascular or respiratory now?
Uh, Sir, it's mostly like the cases of cardiovascular system, sir.
Okay, so cardiovascular system most likely, right? Okay. Okay then. So can you go to the first slide of history of presenting illness?
Yes, sir.
Okay, so basically he is having this progressive breathing difficulty, isn't it?
Yes, sir.
Right? So progressive breathing difficulty, which in medical terms we can also say as dyspnea, right?
Yes, sir.
So progressive dyspnea since 3 months, along with what is this episode what you are trying to explain during the sleep that he gets this breathlessness that occurs around 2 hours after sleep?
Sir, during sleep, difficulty during orthopnea, sir. Orthopnea and PND.
Okay, fine. So exactly. So I think what you are trying to say is this patient also has PND, right? Paroxysmal nocturnal dyspnea, right? So someone who had dyspnea since 3 months now has progressed to having paroxysmal nocturnal dyspnea, right? Then he went to a hospital where he was prescribed some medicines, right? and those medicines somehow helped with his symptoms, isn't it?
Yes, sir.
Right? Okay. So here one thing what we can elaborate is what kind of medicine did he get? Like from
Um,
history also, is there anything we can ask?
Sir, he has mostly used beta blockers, sir, beta blockers kinds of.
Okay, one maybe beta blocker. What else?
Beta blocker and
Okay.
NSAIDs.
Let's see. So basically, paroxysmal nocturnal dyspnea is suggestive of some form of heart failure or
Yes,
early form of heart failure. Okay. And then when someone goes into frank heart failure, there will be orthopnea, isn't it?
yes,
So a couple of hours after going to bed or lying down, if someone develops shortness of breath or dyspnea, that we call it as paroxysmal nocturnal dyspnea, right? If immediately on lying down, if someone develops shortness of breath, that is orthopnea, isn't it?
yes, sir.
So that is basically progression of heart failure, right?
Yes, sir.
Then a medicine that can be given orally to help symptoms of heart failure is diuretics,
Diuretics. Yes, sir.
right? So one other thing that we could have taken in the history is like, did when you took the medicine, did your frequency of urination increase? Because that's what the diuretics do, right?
Yes, sir.
Number one. Number two, diuretics are usually given in the morning and early afternoon. So what was the timing of your medicines, isn't it?
Yes, sir.
So yes, the patient may not be able to exactly tell you the name of the medicine, but from this history also, if someone says that, okay, I used to take a tablet around like 8 a.m. in the morning, then around 2 p.m. in the afternoon, and this medicine made me like go to toilet very frequently or more frequently than usual, then most likely this is a diuretics,
Diuretics. Yes.
right? So this patient got uh, some medicine which improved his symptoms. So most likely one possibility is diuretics, isn't it?
Yes, sir.
Okay. Then one other thing, like suppose this would be a respiratory system involvement. Okay. It still could be, right? Someone with progressive breathing difficulty can still have chronic lung disease, isn't it? So one thing with this history, what we have made clear is this is not any inhaler or anything that's given for chronic lung diseases, right? So this also maybe tells us that maybe it's more towards cardiac disease than the respiratory disease, right? Then one other important thing that you have mentioned in your history is, yes, with use of diuretics, this paroxysmal nocturnal dyspnea, this orthopnea do improve. And that's why I think the improvement in his sleep pattern, right? So I think from your first point in your history of presenting illness, so we may be able to say that some component of heart failure is definitely there, right? We may not be able to exactly say what is the lesion or what is the pathology in the heart itself, but heart failure we can say broadly, okay? Because in heart failure also we do get this kind of symptoms, okay? And whatever the cause, like underlying cause of the disease or the heart failure, we can say that most likely heart failure is there, right? Okay, so to the next slide.
Uh, Complaint of easy
Okay,
fatigability.
so then yes, so easy fatigability for 3 months, right? Progressively worsening. So this can happen in both respiratory disease as well as cardiovascular disease, right? And then you have mentioned worsen immediately after lying supine with no relief with medicine. So that is the progression of the disease, isn't it? So initially, you have mentioned it nicely. Initially, he had exertional breathing difficulty. Then he had paroxysmal nocturnal dyspnea. Then he had orthopnea. This is a classical pattern of evolvement of heart failure. Okay, so you have nicely like depicted it. This is a very like typical feature suggestive of heart failure. Okay, so exertional dyspnea. Initially, he had breathing difficulty when he walked, isn't it? With exertion, climbing the stairs and all. After that, he started developing paroxysmal nocturnal dyspnea, then orthopnea. Then one other thing, is it possible to have paroxysmal nocturnal dyspnea and orthopnea at the same time?
Orthopnea, maybe, sir.
So it's a bit unlikely, right? Paroxysmal nocturnal dyspnea, you need to be, I mean, lying down for 1.5 hours before your dyspnea starts.
Yes, sir.
So for orthopnea, you immediately lie down, you immediately have dyspnea, so you won't be lying down for 2 hours, right?
Yes.
So that is the progression of the disease. So usually, initially it's paroxysmal nocturnal dyspnea, then it goes to orthopnea.
Orthopnea. Okay, sir. Okay.
Okay, unless someone is unlike that, is sleeping on a chair. Unless that happens, usually it's exertional dyspnea, then PND, then orthopnea. Okay, so very nicely mentioned. So one first feature told us it could be heart failure. Number two, easy fatigability, also heart failure versus respiratory system involvement. Yes. Okay, so next slide. Okay, so another thing is palpitation. So palpitation means basically you are feeling your own heartbeat,
Yes.
isn't it? Okay, then, so can you just broadly tell me what could be the cause for this palpitation?
Causes of palpitation, sir.
Yes.
Causes of, at first, I would like to define palpitations is unlawful or unpleasant awareness of one's heart beatings. So palpitations.
Yes. No, I don't want, like, you know, that what is the cause of palpitation? Like physiologically, what causes palpitation? You know, either the heart should beat very fast,
Yes, sir.
or it should beat very low. Okay, if heart is very slow, also you tend to have palpitations. Okay, it's not only when you, I mean, have increased heart rate. So when you have increased heart rates, when you have very slow heart rates, you can have palpitations. Plus, when the contractility of the heart increases, also you can have palpitations, isn't it? So if this person had some kind of heart disease, and then his heart started beating more, like he started having increased heart rate, then is palpitation possible? Yes. Right? So maybe somehow, because of some reason, his heart is starting to beat at a faster rate than usual. That's why maybe he's getting palpitations, right?
Yes.
That is one possibility. Another possibility is there's some abnormal rhythm of the heart, isn't it?
Yes, sir.
So any rhythm that you can tell me which can cause palpitations?
Atrial
Any
fibrillation.
abnormal heart rhythm? Yes, absolutely. Atrial fibrillation, isn't it? So atrial fibrillation or increased heart rate, like sinus tachycardia. So one of these two things could have caused palpitation in this gentleman, right? So from history, can we say, like, is it atrial fibrillation or sinus tachycardia? From history itself, without examining the patient, is it possible?
Sir, atrial fibrillation.
Yeah, go on. You know that, I think.
I mean, sir, atrial fibrillation is studied for the short durations, and sinus tachycardia leads long durations.
That's okay. So what you're trying to say is atrial fibrillation is maybe short-lived compared to sinus tachycardia, right? Which we are thinking maybe it could be in this case. So in your history itself, what you have written is there's regular palpitation, isn't it?
Yes,
so does that mean the rhythm itself? So if you are trying to say that the palpitation is regular in rhythm, so it is unlikely to be atrial fibrillation.
Yes, sir, atrial fibrillation.
Right? Yes. So if the palpitation feels irregular to the patient, then maybe it's atrial fibrillation. Got it?
Yes, sir.
Isn't it? So in
Yes,
the
sir.
history also we can say, जस्तो अब नेपालीमा भन्दाखेरि नि अब सबै चिज ठ्याक्क इङ्ग्लिसमै सबै चिज बुझिँदैन के जस्तो बुवा तपाईको मुटु चाहिँ ढुक 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 गर्छ कि ढुक 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 टुक 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 गर्छ भने यसरी सोध्यो भने भन्नुहुन्छ नि हैन बुवाहरुले आमाहरुले हो बाबु मेरो त त्यो सेकेन्ड वाला जस्तो चाहिँ हुन्छ ढुक 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 हुन्छ अनि रोके जस्तो लाग्छ फेरि चल्छ फेरि कुद्छ फेरि एकछिन रोके जस्तो लाग्छ भन्नुहुन्छ नि so that can be atrial fibrillation.
Okay, sir.
Right? So most likely he does have either atrial fibrillation or sinus tachycardia. Okay, let's keep both the options open, right? We are in no hurry to get to a diagnosis. Okay, so we'll keep our options open for now. Okay, so is palpitation possible in respiratory system? Yes, even in cases of even like chronic obstructive pulmonary disease also we can have sinus tachycardia, we can have paroxysmal atrial rhythms as well. Okay, and there can be some multifocal atrial tachycardia which we call as MAT, M-A-T. Okay, so in that situation also it is possible, yes, right? So yes, palpitation also goes with some with respiratory system also, yes. Okay.
Yes, sir.
So the next symptom is swelling of the legs, bilateral lower limb swelling, isn't it? So
Yes.
up to mid calf, which reduces partially in limb elevation, right? So what does this suggest?
It suggests a kind of heart failure situations.
Yeah. Okay. So again, this points towards heart failure, right?
Yes, sir.
So heart failure means either it's a primary involvement of cardiovascular system, or there's a term called core pulmonary, right? So
Yes,
involvement of the lungs leading to right-sided heart failure can also cause edema, right?
Yes, sir.
Okay, done. So this could be heart failure, and maybe a little bit less likely, yes, respiratory system involvement with right-sided heart failure. That is also possible, right?
Yes, sir.
Okay. So onto the next slide. Okay, so now comes the history of hemoptysis, isn't it?
Yes, sir.
Okay, so blood stained sputum for 2 months, right? Yeah, so no postural change, seasonal variation maybe for 2 months. We may not know too much about the seasonal variation anyway, but anyway, so he had hemoptysis as well, right?
Yes, sir.
So someone has hemoptysis also. So again, which system is likely to be involved?
It might be respiratory system, cardiovascular systems.
Okay, so again, it's possible that respiratory system is involved,
Yes, sir.
and then cardiovascular system involvement is also possible, right? So in heart failure, is it possible to have blood-stained sputum?
Heart failure, in the case of right side heart failure, due to pulmonary congestions or thromboembolisms, there is chances of blood stains.
Yes, absolutely. So more of in left-sided heart failure, you can have pulmonary congestion, and you can have like pink-colored frothy sputum as well, right? And one other thing, like during your presentation of edema itself, was there any like facial puffiness, anything?
There are facial malors in the
No. Was there any puffiness of the face or swelling around the eyes?
no, sir. There is
No, just what I'm trying to say is like usually if there's a swelling of the leg, suppose edema anywhere in the body, right? Immediately, like where there's involvement of the kidneys, isn't it? That comes to our mind. So if there's no involvement of the face, like no facial puffiness, if it starts from the legs, again, that is more suggestive of involvement of cardiovascular system, right? Okay, then. So there was no chest pain, no syncope, no fever, no abdominal pain, no facial edema, no hoarseness of voice, any discoloration of the body, right? Okay. And one thing is, can we go to the next slide? Is it the differential diagnosis one?
Yes,
okay, the previous slide. Okay, so maybe a little bit, we didn't discuss a lot about the cough, isn't it? Was cough a major symptom?
Yes, sir. Cough present system, cough present symptoms sign.
No. Did this patient had cough which was significant? No, it doesn't need to be there. Okay, maybe it's patient, the patient could have exactly told you like this. And sometimes I get some blood in his sputum, but I do not have a lot of coughing. You can say like that. There's no like big deal in that one. Okay, so now with all these things in mind, so what could be our like systemic involvement? So again, cardiovascular plus respiratory system involvement, right? So in the cardiovascular system involvement, with breathing difficulty associated with PND, orthopnea, then palpitations. So what are the possibilities? Heart failure,
Yes, sir.
right? Whatever cause, we may not know at this point of time. Okay, then respiratory system involvement with core pulmonal, maybe, right?
Yes, sir.
So those are the possibilities that we can think of, isn't it?
Yes.
Okay, now let's try to narrow the details little bit. Okay, so usually if there's features of PND, orthopnea with exertional dyspnea and all, usually it's feature of more left-sided heart failure, right? Okay, so now coming to the left-sided heart failure, what pathologies in the left side of the heart can cause left-sided heart failure?
So volume overload increases in case of mitral stenosis or mitral regurgitation.
Yes. Okay. So no, we'll go to that later. Okay. So what are the pathologies or the structures you think could be faulty that can cause left-sided heart failure? So one is, I think you are trying to say mitral stenosis.
Yes, sir.
Right?
Valve.
Okay, good. So mitral stenosis, can it cause these symptoms? Yes, absolutely. What else?
Sir, if there is any kinds of defect in cauda tendinae or papillary muscles of left ventricles.
Okay. So maybe you're trying to say mitral regurgitation also.
Yes, sir.
Right? So two lesions of the mitral valve, mitral stenosis or mitral regurgitation, right? Okay. Then could aortic stenosis can lead to left-sided heart failure?
Yes, sir. Sometimes.
So left-sided heart involves even aortic valve as a unit. We can say like that. So it could be aortic regurgitation or aortic stenosis also maybe. Is it?
Yes, sir.
Yes. What else? Anything else in the left side of the heart that you can think of that can cause this kind of symptoms?
Sir, congenital heart defect?
Yes, absolutely. So congenital heart diseases. Can congenital heart diseases present in like elderly patient like this?
And it's no, sir. Congenital
yes.
heart.
No. They can present, okay? Even though they are congenital heart diseases can present in adults also. It's not necessary that congenital heart diseases should present in children only, okay? So definitely, so congenital heart diseases. What is the heart disease? We may not exactly know at this point of time, okay? Okay, what else? See, okay, again, I'll try to make it easy, okay? Okay, just a minute. So from inside to outside, okay? So from deep inside, you took the valve, right? So mitral valve, aortic valve. So just outside that, what is there?
Endocarditis, sir.
Okay, so if it's an acute onset disease, it could be endocarditis also, yes. Okay, but what goes against endocarditis? Absence of fever. Clearly mentioned, there's no fever, but yes. What else? Just outside the endocardium, if you go towards the pericardium, between the endocardium and pericardium.
Myocardium. Myocarditis.
Yes, absolutely. So is there any disease that can affect the myocardium?
Myocardium.
Something we call as cardiomyopathies. Yes, so cardiomyopathies, isn't it? So that can also give rise to features of heart failure, right? So left side of the heart side, suppose left-sided myocardium is affected, left-sided cardiomyopathies can also give rise to this kind of symptoms, right? Okay, so And then even some lesions of pericardium can also give rise to this kind of symptoms, okay, like chronic pericarditis. Okay.
Pericarditis.
Okay. Yes, chronic constrictive pericarditis can also sometimes give rise to this kind of symptoms. Okay, so that's fine. So we do have some differentials, isn't it?
Yes, sir.
Right? So we do have some differentials. And then, okay, let's come to the respiratory system. Any disease that you can tell me which could have caused this kind of symptoms? Can you name a few diseases? Breathing
So pulmonary
difficulty.
hypertension.
Okay, pulmonary hypertension. Okay. What else?
Pulmonary hypertension.
Like, is it possible in chronic obstructive pulmonary disease
Yes, it might be in case.
or interstitial lung disease? So those are the common like respiratory diseases we could encounter in elderly patients, isn't it?
Yes,
okay. So can we go back to the first slide, history of presenting illness, just before that, the presenting complaints? Yeah, just before this one, presenting complaints itself. Okay, so good. So now we'll try to see whether any respiratory diseases fit into the criteria, okay? So overall, like if you do not put a time frame, if you just say difficulty in breathing, fatigability, palpitation, swelling of the both limbs, yes, we would say that maybe a respiratory disease is also a possibility, right? But now in chronic obstructive pulmonary disease also, there would be significant cough, right? In interstitial lung disease also, there would be significant cough, isn't it? Dry cough, which is very like typical of interstitial lung disease. And if you know the definition of like chronic bronchitis, what does it say?
Chronic,
For 3 months,
between
over
the
2 years,
within the, yes, sir.
right? So does chronic bronchitis fit into this?
Yes, sir. When productive cough increases in case
Yeah,
of
productive cough and all those things will be there, but the time frame doesn't match. So it's only 3 months of shortness of breath, isn't it?
yes, sir.
So even to like qualify for chronic bronchitis also, you should have at least like 2 years of illness with 3 months
Yes,
of intermittent illness in between, isn't it?
yes.
Right? So yes, if it may be that it's a very early phase of chronic bronchitis, which you may have detected early, but still, like for our practical purposes, we'll say that chronic bronchitis or COPD or interstitial lung disease is less likely, right? So what happens is swelling of the limbs in respiratory diseases usually is because of the chronic lung diseases, isn't it?
Yes, sir.
And because chronic lung disease from the history, like chief complaints itself, is a little bit less likely, possibilities of poor pulmonal is again less likely. Correct?
Yes,
so from the history itself, so chief complaints and history of presenting illness, so we think that maybe it is more of cardiovascular system involvement rather than respiratory disease, right? So
yes.
maybe we can think that cardiovascular system is possibly the culprit in this case, isn't it? Okay, so at the beginning I told you any other system, just one disease that I would like to throw into the ring. Can this be anemia?
Yes, sir. It can be anemia, sir.
Yes, difficulty in breathing and walking.
Yes, sir.
Anemia can sometimes lead to heart failure as well. Because of tachycardia, there could be palpitations, right?
It might be caused in case of obesity, sir. Obese person, obesity.
Obesity. Okay. In obesity, actually, like there could be difficulty in breathing, but there is unlikely to have, palpitations, difficulty in breathing, coughing, plus hemoptysis and all those things. Features of heart failure, a frank heart failure are there in your case, right? So in obesity, difficulty breathing is more because of we call as deconditioning, okay?
Yes,
So that is because of more of involvement of the metaboreceptor. So that's because of deconditioning. So that's a bit unlikely. But anemia could also lead to these symptoms, isn't it?
yes,
Right. So if like you had anemia in your mind at the beginning, what question would you have asked the patient? A simple question you could have asked, and probably you would have got the answer. Or you could have asked to the bystanders also.
uh,
Does he look
pallor, it's
paler compared to before? Isn't it?
yes, sir.
So if you like, some people say that okay, I have become a little bit yellowish or whitish. Okay, so एउटा नेपालमा चाहिँ के पनि छ भने मान्छेहरूले चाहिँ म पहेँलो भएँ भन्छन् के
हजुर
त्यो रातो हुन्छ नि रेडनेसबाट चाहिँ व्हाइट हुनु त्यो प्यालर भन्छौँ हामी इङ्ग्लिसमा चाहिँ तर नेपालमा चाहिँ अलिकति पहेँलो भएँ भने जस्तो गर्छन् के
हजुर
त्यो सेतो भएँ भन्दा पनि पहेँलो भएँ भन्छन् अनि हामीले सोद्धाखेरि चाहिँ जस्तो तपाईँको हात चाहिँ पहिला भन्दा सेतो लाग्छ कि लाग्दैन आफूलाई अलिकति पहेँलो लाग्छ कि लाग्दैन अथवा त्यो पेशेन्टलाई लिएर आउने छोरा छ भने छोरालाई तपाईँको बुवा चाहिँ पहिला भन्दा अलिकति पहेँलो अथवा अलिकति सेतो सेतो बन्नु भएको जस्तो तपाईलाई फिल हुन्छ भनेर सोध्यो भनेदेखि भिजिबल प्यालर चाहिँ थाहा हुन्छ है अनि for anemia to cause this level of breathing difficulty, fatigue, palpitation, swelling, usually the hemoglobin should be around 7 to 8, which can be clinically detected.
Yes, sir.
Right? So, so those diseases can be our differentials. Okay, so most likely this is a heart failure, some kind of heart diseases. We don't know myocardium, endocardium, pericardium till now. Okay,
yes,
so maybe from history after examination and all those things we'll find out. Okay, so let's go to a differentials whether we are in the correct path. Okay, so luckily all the differentials I think are correct, isn't it?
Yes, sir.
So at least one thing is very clear. So your differential diagnosis, when you thought about it, you thought about congenital heart disease, mitral stenosis, tricuspid stenosis, left atrial myxoma, mitral regurgitation, right? So all cardiovascular system involvement, right? So you also thought that maybe respiratory system involvement is a bit unlikely, right? Yes. Okay, so congenital heart disease, mitral stenosis, tricuspid stenosis, so, and then the mitral regurgitation, left atrial myxoma. So from history, is there any way we can say that possibly it could be atrial myxoma?
Atrial myxoma भनेको सर atrial fibrillations को केसेस भएको कारणले गर्दाखेरि भनेको palpitations भइराछ
हैन हैन लेफ्ट एट्रियल myxoma को क्लिनिकल फिचर्स केही थाहा छ
त्यस्तो छैन सर
Okay, so left atrial myxoma can also present exactly like mitral stenosis. Okay, so this is I would say a good differential diagnosis. Okay, so if you are thinking mitral stenosis as one of your differentials, left atrial myxoma absolutely can mimic mitral stenosis. Okay, but there will be other features like fever, weight loss, and all. Okay, so we will discuss about that a little bit later. But yes, hemodynamically also and auscultation findings wise also, left atrial myxoma should be kept in a differential diagnosis of mitral stenosis. Okay, and I think just it popped up on my screen. Someone is asking whether we should include respiratory diseases in the differentials. Okay, so you can include at this point of time. Okay, but broadly what you can say is maybe right-sided heart failure. Okay, with some underlying chronic lung diseases. Okay, but that will come a bit lower down the list, basically because we do not have cough, significant cough. That's what I asked you, isn't it?
Yes, sir.
Then the duration of illness is relatively short.
Short periods.
Okay.
Yes.
Usually what happens is like in COPD or ILD or bronchiectasis, which are the usual lung diseases, the history would be pretty, long. Okay.
Yes.
In COPD, as I told you already, usually it's like 2, 3, 4 years of illness with cough, productive sputum, with periods of exacerbations, which is not present in this patient, right? Then in bronchiectasis, you would have a very clear-cut history of coughing plus copious amounts of sputum production, postural variation in the sputum production, right? And then interstitial lung disease, there's a very like a typical dry cough with exertional dyspnea, right? So those are the likely possibilities. If anything, maybe interstitial lung disease with right-sided heart failure, we can keep maybe towards the end of the differential diagnosis. Okay. Okay, so let's move on.
Past history, he has no history of migratory joint pain, and he has no history of hypertension, asthma, diabetes mellitus, tuberculosis, and he has no past surgical history.
Okay, just a minute. Okay, so maybe by saying that, trying to say asthma, maybe what you're trying to say is this patient did not have any breathing difficulty in the past, is it?
Yes, sir.
Right? So maybe he did not have any breathing difficulty in the past. This is a breathing difficulty of relatively short onset, right? Yes. So maybe again, chronic lung disease, a bit less likely. Obviously in medicine, we cannot say it's not there, it's not possible. Okay.
Yes, sir.
But yes, this is a bit less likely. Okay. Then no history of past surgery. Migratory joint pain. For?
Migratory joint pain.
Yes. For rheumatic fever, maybe?
Rheumatic fever, especially in case of
Okay, good. Okay. Okay, so let's move on.
Personal history.
Just a minute, okay? One more question. I'll try to incorporate your questions. Differentials, PDA, VSD, how to rule out this now in this age group. Okay, so we'll come to that later, okay? We'll come to the cardiovascular system among the diseases itself. We'll try to differentiate from history as well as examination. Okay, so let's move on. Yes, personal history.
Okay, personal history. He's vegetarian. He's non-vegetarian by diet, and he's non-smokers. And occasionally he used to consume alcohol. And he has a sleep pattern was disturbed, and he has normal bowel and bladder habits. सर सुनिराख्नु भएको छ?
सर डिस्कनेक्ट हुनुभएछ, नेट गयो जस्तो छ, एकछिन वेट गरौँ है।
सर डिस्कनेक्ट हुनुभएछ। सर डिस्कनेक्ट हुनुभएको छ। एकपटक फेरि हेर्दै गरौँ न त अगाडि एचओपीआई नै।
अहिले आयो मेरो?
हजुर दाजु, हजुर आउनु भयो हजुर। हजुर सर।
Okay. So let's move.
Personal history. He is non-vegetarian by diet, and he is non-smoker. Occasionally he used to consume alcohol, and his sleep pattern was disturbed, and he has regular normal bowel and bladder habits.
Okay. So just in this one also, non-smoker, any importance of this thing?
Non-smoker means it's not maybe a respiratory disease, sir.
Yeah, so less risk of respiratory diseases, right? COPD, ILD, both can be predisposed by smoking, right? Okay, yes, okay. Let's move on.
Family history. Altogether, there were five family members in his family: 2 daughters, 1 son, wife, and himself. And there is no history of heart disease in his family, and no history of hypertension, TB in his family, and his father was died due to diabetes mellitus.
Diabetes. Okay. Okay. Let's go on.
Socioeconomic history: he belongs to the middle class family. He lives in semi-pakka house with well ventilations, and he has separate kitchen and sleeping rooms. He used to cook. He used to cook with the help of LPG gas and used hand pump for drinking water and other purposes. He used sanitary latrine.
Okay. Okay. Just one more thing I would add here. Uh, Cooking food in LPG origin. So what you can write is even in the personal history also.
Yes,
For COPD, for ILD, also for lung diseases, exposure to smoking plus indoor air pollution, right? So these things, non-exposure to like firewood and non-smoker again goes against like the possibility of exposure to the smoke causing lung diseases, isn't it? So that's also one important point. Yes. So let's move on.
drug allergy history. He has no any
Okay.
drug and food allergy history, sir.
Okay, fine.
Now we move to general
Okay,
exam.
so at the end of the history, what we think is most likely it is some cardiovascular disease causing heart failure, right?
Yes, sir.
And then we do have lots of differentials. Then less likely, but maybe there's a slight possibility of respiratory disease, right? Okay. And then okay, maybe severe anemia, less likely, right? So those were our differentials. So now from history, we'll try to pick one of them. Okay.
Yes, sir.
So let's move on to the examination findings. Sorry, let's go to the examination findings.
General examinations.
Okay.
A middle-aged male, well-built and well-nourished. He is cooperative, conscious, and well-oriented to the time, place, and person, sitting on bed with IV cannula on his right-hand sides. He has on pill code examinations. He has bilateral pitting edema, and he has no
Yes.
pallor, icterus, cyanosis, clubbing, and lymphadenopathy.
Okay, so very simple now. So it's not anemia, isn't it, causing heart failure?
Yes, sir.
Because we have clearly mentioned it's no pallor, right? So that's how we like go on like removing our differentials now. Okay, so there's no icterus, there's no cyanosis, there's no clubbing and lymphadenopathy, no pallor, right? So these things will also help us definitely. Okay, so in edema, what you can mention is when you describe edema, you can describe the grading of edema also. Okay, there's a grading, grade 1 to 4. 1 is like barely you can feel, 2 is a little more, 4 is like massive edema. Okay, so based on that also you can later find it out, but it's okay. So bilateral pitting pedal edema, isn't it? Okay, done. So what does this suggest? So again, maybe heart failure, maybe right-sided heart failure due to lung disease, right? Okay, one more thing, there's no cyanosis, right? So in patients with chronic bronchitis, we do find cyanosis in some cases, is it?
Yes.
Central cyanosis, possible, isn't it?
Yes,
So
sir.
there is no cyanosis and there's no clubbing, isn't it? So there's no clubbing means clubbing is a typical feature of interstitial lung disease. Okay, so absence of clubbing also goes against interstitial lung disease. Okay, in bronchiectasis also we will find clubbing. So absence of clubbing means maybe bronchiectasis is also a little bit less likely. Okay, it won't rule it out, but definitely it gives us a clue. Okay, let's go on.
His general vital examinations. His
Okay.
pulse rate was 80 to 87 beats per minute. Regular high volumes, non-collapsing, non-thickened vessels wall. Peripheral pulses, all peripheral pulses were felt. No radial or radiofemoral delay present.
No radiofemoral delay present. Okay, very good. Now, from this pulse rate, it is atrial fibrillation or it is a normal sinus rhythm?
Atrial fibrillation cases, sir.
But you have written it's regular, right?
Yes, sir.
So either it could be normal heart rate, or maybe because he had taken some medicines also, maybe. So atrial fibrillation may have reverted also. We don't know, but at this point of time, most likely the patient does not have atrial fibrillation. Correct?
Yes, sir.
That is one thing. Yes. Then a very important point in this radiofemoral delay was disease can cause this delays. Any cardiovascular disease in which you find radiofemoral delays, involvement of the aortic valve, maybe.
Aortic stenosis, it's aortic stenosis cases, no, sir?
Yes. Yes. So one of you, I think, posed a question like importance of syncope. I think some of you wrote no history of syncope. There must be syncope. So exactly. So syncope is a typical feature of aortic stenosis. Okay. So you have mentioned in your history, I think, no history of syncope, isn't it? So no syncope, no radial, no radiofemoral delay. So maybe aortic stenosis less likely. Okay. So that's the importance. Let's move on.
Blood pressure examinations, right upper limb 130 by 70 mm of Hg, lower upper left upper limbs 130 by 70 mm of Hg, and lower legs 150 by 74 mm of Hg, and left lower legs blood pressure was 150 by 74 mm of Hg.
Okay.
Impressions.
So what I can see is maybe the pulse pressure is a bit on the higher side.
Yes, sir.
Is it like any significance of this blood pressure?
Sir,
you have mentioned heel sign positive, isn't it?
Yes.
So do you want to like say something? Like, were you trying to mention something by saying that heel sign is positive?
Sir, heel signs is positive, especially in case of mitral stenosis.
Okay, not so much in mitral stenosis, I think. Maybe what you are trying to say is the difference between the systolic and diastolic blood pressure is a little bit high. The usual difference is 30 to 60. Okay.
Yes,
so if it's more than 60, it's high. If it's less than 30, it's low. So when, yes, the difference is a bit high, that is suggestive of aortic regurgitation or mitral regurgitation in some cases, or in cases of severe anemia. Okay, so
yes,
those are the likely things. All right, but till now, so if at all this is like a significant finding, maybe aortic regurgitation could come into consideration. Anyway, that is also like one of our DD, isn't it? But
yes,
from your pulse rate, what you have clearly mentioned, it is a non-collapsing pulse. So usually in AR, there would be collapsing pulse. Okay.
yes,
so no problem. So it may sometimes like during measurement of blood pressure also we may find this kind of findings, but if there are no other findings suggestive of aortic regurgitation, we may not like think too much about it. Okay, so let's go on.
Respiratory rate is 15 per minute, and temperature was 98.6 degree Fahrenheit, and no elevated above sternals in jugular venous pressure, sir.
Okay, JBP is not raised. That's what you say, right?
Yes, sir.
Okay. So we were thinking that this could be a case of heart failure, but in heart failure, the JBP will be high. So does it fit?
JBP.
Yes, it will fit because this patient is getting diuretics most likely. Right?
Yes, sir.
So it is, yeah, it is possible. Yes, at this point of time. Okay, so let's move on.
CVS clinical examinations, on inspections, the chest wall appears symmetrical.
Okay. Anything significant in inspection? No, nothing significant, right?
Yes, sir.
Okay. So let's move on to the next one.
Palpitations.
Okay, palpation. Yes.
Was normal.
Palpation also, I think you have written tapping in nature, apex bit. You could feel the tapping apex bit, is it?
Yes, sir.
Yeah, so when like S1 is palpable, we call it as a tapping apex bit. Okay, and you have palpated, I think, thrill also in the mitral area.
Diastolic thrill, yes, sir.
Right? Okay, so these things will help us narrow down the differentials now. No heave is present, means any type of heave is absent, and no tenderness. Okay, so diastolic thrill means?
Visualizable palpitations.
So you felt that there is some, what to say, some pulsations in the mitral area, right?
Mitral area, yes,
So
sir.
that means there must be diastolic murmur in your auscultation findings. So let's go on whether it's there or not.
Yes, sir.
Okay.
And
So percussion, anything significant?
yes, everything is normal, sir. The 15 goes to
Okay.
this. This. On auscultations at mitral area, first and second heart sound are heard. S1 is loud and opening snap are present. A low
Okay.
pitched, rough rumbling, mid diastolic
Okay.
murmur of grade 3 heard with the bell of stethoscope in left lateral positions when the breath held at the end of expiration. And
Okay.
there is no any added sound. On auscultations to the tricuspid area, we found first and second heart sound are heard and no murmur or added sound found in tricuspid area.
Okay. Okay. Fine. So now, from whatever you are telling me, now I think we can narrow down our differentials a little bit more, right?
Yes, sir.
Okay. So loud S1, isn't it? So if we go to the differentials, loud S1 is significant for any disease?
Atrial fibrillation.
No, loud S1 is for mitral stenosis.
Mitral stenosis. Okay, sir.
Right? Opening a snap is also for mitral stenosis, right? And you have said mid diastolic murmur, isn't it?
Yes.
So that's again in favor of mitral stenosis, right?
Yes.
Okay. Then, okay, a little bit about the murmur we'll discuss a little bit later. Okay, tricuspid area, first, second heart sounds heard, no murmur. Okay, let's move on.
On auscultations to the pulmonary area, first and second heart sound are heard. Loud
Okay.
P2 is heard, and A2 P2 is split is and no murmur.
Okay. Okay. Good. So loud P2 is heard means when P2 is loud, that is suggestive of pulmonary hypertension. Right. Yes. So this patient has most likely mitral stenosis plus pulmonary hypertension. Is it possible?
Yes, sir.
Yes, absolutely. Yes, let's move on.
On auscultations to the aortic area, the first and second heart sounds are heard and no murmur or added sounds.
Okay, good. So you could find nothing abnormal with aortic heart sounds. That's what you're trying to say, right?
Yes.
Or you could not hear any murmur in the aortic area, isn't it?
Yes.
So now I think aortic regurgitation, aortic stenosis are out, right?
Yes.
Okay, so next slide.
Other systemic examinations, and first of all, in respiratory system, bilaterals, basals, crackles.
Okay, bilateral basal crackles. So bilaterally in the infrascapular area, there are crackles, right? Then there's nothing else mentioned in the respiratory system. So maybe what you are trying to say is it's a normal vesicular breath sounds and no other added sounds apart from the basal crackles, isn't it? Okay, that's fine. One thing in the respiratory system that you have not mentioned, but that will help us is maybe the shape of the chest, like barrel-shaped chest, isn't it? So those things, if they would be present, they would maybe suggest hyperinflation, maybe going towards COPD and all, right? But because those things are not there, only positive findings in the respiratory system being basal crackles, isn't it? So is that possible in heart failure? Yes, it is possible, right? So in heart failure also, you can have bilateral basal crackles because of pulmonary congestion. Okay, so good. Anything else? Any other system?
Gastrointestinal systems, ascites, maybe presence of ascites.
Okay, there is ascites, right? Okay, okay. And there's hepatomegaly also. Okay, now things I think slowly falling into the place, isn't it? Now we thought it could be mitral stenosis, we thought it could be pulmonary hypertension, we thought it could be right-sided heart failure, and there was plus one other thing we should not forget is there is left-sided heart failure, features of left-sided heart failure, because there's exertional dyspnea, PND, orthopnea with bilateral basal crackles, right? Now we have features suggestive of right-sided heart failure also with pedal edema, ascites, and hepatomegaly, right?
Yes, sir.
Okay. Any other system you have mentioned?
In neurological systems,
Neurological, nothing significant, right? Okay. Anything else?
finish the general examination.
Okay. Okay. So in the investigations, anything significant?
So no, sir,
So
normal.
CBC,
So hemoglobin
okay.
normal, normal, sir, neutrophil normal, sir.
Normal. Okay. So,
No.
so anemia was already out
Out,
because
sir.
there was no pallor. Now this confirms there's no anemia, right? Okay, fine. And so your creatinine level is 1.4. So normal creatinine, right?
9 to
So
1 mmHg.
swelling because of kidney, yeah. So swelling of the limbs because of the kidney involvement is unlikely again, right? Okay. Next slide.
Chest X-ray, X-ray findings. Sir.
Okay. So you will come to this later. Okay. So can we go to that slide of differential diagnosis now?
Yes, sir.
Okay. So now you can tell me whether this is mitral regurgitation or not.
Mitral regurgitations, mitral regurgitations.
So just a minute. Okay. So what we have is left-sided heart failure,
Yes, sir.
pulmonary hypertension,
Hypertension.
right-sided heart failure. So that is something we call as congestive heart failure. We can say like that, isn't it?
Yes.
In older terms, we can say so. Left-sided heart failure, pulmonary hypertension plus right-sided heart failure, right? Okay, so can mitral regurgitation cause left-sided heart failure, pulmonary hypertension, and right-sided heart failure? Yes.
Yes.
But based on your examination findings, your S1 is loud, whereas in mitral regurgitation, S1 should be soft.
Yes, sir.
Right? Then it's not a tapping apex bit in mitral regurgitation. Okay?
Yeah.
And then maybe most importantly, there's opening snap and there's a mid diastolic murmur.
Yes, sir.
Right? So in mitral regurgitation, you will have
sir, the heartbeat
pansystolic murmur.
sir,
There will be pansystolic murmur.
pansystolic.
Right? So mitral regurgitation is out now. Satisfied?
Yes, sir. To start the heartbeats attack.
Is a sign that this is unlikely to be mitral regurgitation.
Regurgitations.
Right? So we don't think now this is mitral regurgitation. All right? Okay, left atrial myxoma. Is it possible?
Maybe chances of
yeah, because I told you before also, hemodynamically or sometimes even auscultation wise also, left atrial myxoma can definitely mimic mitral stenosis. But left atrial myxoma is basically a myxoma that is hanging from the atrium and just causes obstruction to the left atrial outflow. Okay, so when you change the position of the patient, the auscultatory findings change absolutely.
okay, sir.
Okay, plus there will be features of fever, cachexia, and then in investigation findings there will be increased ESR, there will be history of weight loss, and also in absence of all these things, left atrial myxoma is also unlikely. Okay, and now let's come to tricuspid stenosis. Is it possible?
Tricuspid stenosis को cases नहीं GBP पनि
See, it's a isolated tricuspid stenosis. Sorry?
JBP sir,
sorry.
JBP भनेको त्यहाँ देखि जुगुलर भेनल प्रेसर राइज भएको छैन.
Yes. ठिक छ, त्यो पनि ठिक छ हैन. But more importantly, this patient has left-sided heart failure, pulmonary hypertension, right-sided heart failure, whereas tricuspid stenosis would only cause features of right-sided heart failure maybe, right?
Yes, sir.
So we think the pathology is somewhere in the left ventricle, left side of the heart, isn't it? So, and isolated tricuspid stenosis without mitral stenosis is a bit unlikely. if it is severe enough to cause this kind of symptoms. Okay.
Yes.
So tricuspid stenosis also we think unlikely. So mitral stenosis, is it possible? Yeah.
Yes,
it is possible, right? So exertional dyspnea, paroxysmal nocturnal dyspnea, going to orthopnea, so heart failure because of mitral stenosis most likely till now. Okay. Okay, then let's go to congenital heart diseases. So atrial septal defect, is it possible?
No possible, maybe not possible, sir. Cyanosis absent, sir.
Sorry.
Cyanosis absent, sir. Maybe not possible. No, sir.
Yes. So what you're trying to say is there is no cyanosis, isn't it?
Yes, sir.
Yeah, there can be cases of atrial septal defect which can be acyanotic. Okay, but one very important thing that you have mentioned is in your auscultation finding, okay, there is no wide fixed split A2P2.
Yes.
Right? So
Yes,
that goes against atrial septal defect. Okay, but yes, atrial septal defect is also one of the close differential diagnosis of mitral stenosis. Okay, and in atrial septal defect, there will not be mid-diastolic murmur over the mitral area. Okay, but yes, because of increased flow over the tricuspid valve, there can be like diastolic murmur over the tricuspid area, but not over the mitral area. Okay.
yes,
Then BSD, is it likely? So in ventricular septal defect, there will be what kind of murmur? That's a pansystolic murmur. Okay. So mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. MR, TR, and VSD, they are the lesions with pansystolic murmur.
Okay, sir.
Right? Then you could not feel any systolic thrill also.
Okay, sir.
You have clearly mentioned you have also like palpated a diastolic thrill, right? So ventricular septal defect, if it would be causing this kind of heart failure, the severe VSD, so there would be palpable maybe thrill that would be present at somewhere around the lower sternal border, systolic thrill maybe, and more of pansystolic murmur, isn't it? Or early ejection systolic murmur also is possible in late cases. Okay, is it likely to be PDA?
PDA, sir.
Usually, PDA is a bit unlikely, but if at all this would be PDA, what would be the positive finding?
PDA, sir.
So PDA
Sir,
is
we can find
basically
cardiomegaly, sir. Cases of cardiomegaly.
Yeah, that is possible, but like clinically, ductus arteriosus connects with two vessels.
Pulmonary aorta to the arc of aorta.
So pulmonary artery and
Pulmonary artery to the arc of aorta, sir.
Aortic arch or aorta, whatever you say. Okay, so because of the increased flow there, you could find some kind of murmur there.
Yes, sir.
A continuous murmur. Okay,
Yes,
so
sir.
is there any continuous murmur present there?
No, sir.
No. So because of the continuous flow of the blood throughout the duct, throughout the cardiac cycle, there would be continuous, even machinery-like murmur, isn't it? So again, this PDA is looking a bit less likely, right? So from all these things, we think that mitral stenosis is the most likely diagnosis, isn't it? Okay, so we think like left-sided heart failure because of mitral stenosis leading to pulmonary congestion that led to breathing difficulty, difficulty walking, paroxysmal nocturnal dyspnea, orthopnea. Then is there a possibility of hemoptysis in mitral stenosis? Yes, absolutely. And then leading to right-sided heart failure. So things do match, isn't it? Right? Okay, so let's go to the investigations.
First of all,
Okay, so in X-ray, so what will happen is basically because the mitral valve is stenotic, the left atrium, which is just proximal to the mitral valve that will get dilated. Okay, so that will present as a straightening of the left heart in the X-ray, right? This is not so clear cut in this X-ray, but you can see features of, I think, right ventricular hypertrophy in this case. Okay, features of right ventricular hypertrophy because of pulmonary hypertension.
Hypertensions.
Okay, yes, and plus one other thing in this X-ray is there is no hyperinflated lung fields, right? No cystic lesions or bronchiectatic lesions. So again, maybe chronic lung diseases a little bit less likely. Okay.
Yes, sir.
Then I don't know whether I'm not seeing this, but there can be, you can see some curly lines in X-rays as well. Okay, but maybe the patient is decongested already. We may not find all those things. Okay. So next.
ECG findings, sir.
Okay, so in the ECG, basically, there will be features of left atrial enlargement. Okay, so if you can, if you see lead 2, okay, so can you see the P waves being a little bit, what to say, taller in lead 2, not B2, in lead 2. Compare P wave of lead 1 and lead 2.
Yes, sir.
So P wave is definitely taller in lead 2, isn't it?
Yes, sir.
Right? And then you can see features of right ventricular hypertrophy and all those things. But for, I think, what's good enough for you is to know that there will be features in ECG suggestive of atrial enlargement, left atrial enlargement, okay, and then features suggestive of right ventricular hypertrophy, okay. Plus, does this patient have atrial fibrillation currently?
Atrial fibrillation?
No. No, because we are clearly seeing the P waves. Whenever P wave is visible in ECG, this is not atrial fibrillation. Okay, yes. So that's why when you told in the history itself, you told the palpitation is regular, isn't it? Right?
Yes, sir.
You told in the history palpitation is regular. You wrote in your examination that heart rate is regular, and now in the ECG also we can find P wave. So that means definitely your history was taken properly. So most likely that palpitation was because of tachycardia and not atrial fibrillation.
Yes, sir.
Okay, so we can see features of atrial fibrillation also in ECG of mitral stenosis patient. Okay, okay. Next slide.
Echocardiogram, sir.
Okay, so these are the echocardiographic findings. So this is a fish mouth appearance. I think that's what's being tried to show. Okay, very importantly, there will be very much calcified mitral valves in cases of mitral stenosis. So those are the things we'll see in the echo. So this is a calcified valve, number 1, okay? And number 2, the valve orifice, when we measure, it will be very, very small, depending on the severity of the disease, okay? And from the echo, just I'll let you know, if it is like more than 1.5, we call it as a progressive mitral stenosis. Between 1 and 1.5 square centimeter, we call it as severe
mitral stenosis,
isn't it? Yes. And then if it is less than 1 square centimeter, we call it as
severe form of mitral stenosis.
Yeah, that's a critical MS, we can say, okay, or very severe, whatever you say. So the importance of that is depending on what to say is like severity of the disease. Also the management differs, okay. Plus one more thing is, while doing echocardiography, we do the Doppler studies, okay? So that will tell us like how much time does it take for the blood to flow from left atrium to left ventricle, okay? So that time is also important, okay, as far as the treatment of the disease is concerned, okay? So a little bit when we discuss about the management, we will talk about that, okay? And one question is there, transthoracic or transesophageal echo? Yes, first thing we do is transthoracic echo, definitely, okay? Then if needed, if we are trying to look for thrombus and all those things, then maybe we can go for this transesophageal echo, okay? Yes. But otherwise, no need to go for trans esophageal echo for usual management of the patients of mitral stenosis. Okay. Okay. Any other slides you have, or that's it? Okay. So what you say is, yeah, you can go to the last slide.
Yes, sir.
So what you're trying to say is, so probably this is a case of mitral stenosis, rheumatic in origin. Any specific reason why you say rheumatic in origin?
सर त्यहाँनिर क्याल्सिफिकेसन्स एन्ड फिब्रोसिस देखिएको छ मिट्रल भल्भमा.
Okay, okay. Other thing is, like whenever we do diagnosis of a disease, we take into account epidemiological factors, right?
Yes,
so in our part of the world, mitral stenosis still is like what we can say is caused mostly by as a sequelae of rheumatic heart disease, isn't it? So even if we do not find a history of rheumatic heart disease also, that doesn't matter for us. Rheumatic heart disease is still like the most common cause for mitral stenosis. There are some other causes of mitral stenosis, like congenital mitral stenosis, right? And in some connective tissue disorders also, there can be cases of mitral stenosis, but usually till now in our region, the odds are rheumatic fever or rheumatic heart disease is the most likely cause for this mitral stenosis. Okay.
Yes,
and plus one other thing is depending on the progress of the disease also, like if the disease is not so severe, it will manifest a little bit later. If the disease is not so like forgiving, or if the lesion is very severe, it can manifest quite early in the course of disease. Okay, so that's all depends, but for us, we almost take it for granted that most likely rheumatic heart disease or rheumatic fever most likely leads to this kind of things. Okay.
yes.
And one thing is, do we need to have a history of joint pain or sore throat, isn't it? So usually what happens is around almost like 50% of patients even do not give a history. Okay. And then recently a study was done, okay, in Nepal itself, where like echo was done in lots of school-going children, okay, who did not have any obvious symptoms of rheumatic heart disease. But we did find lots of cases of subclinical, means not clinically diagnosed rheumatic heart diseases, okay, and they would progress to have frank or clinical rheumatic heart disease later in their life. Okay, so that was what was found. Okay, so I think that's all you have, is it?
Yes, sir.
Okay, so quickly I'll talk about how to manage a case of rheumatic heart disease, okay, especially the rheumatic heart disease related mitral stenosis. Okay, so as I told before, it depends on like the severity of the disease, okay, and then depends on the gradient also. Gradient means how much pressure the atrium has to like push against the mitral valve to get the blood from LA to LV. Okay, so depending on those things, we can we do manage mitral stenosis. Okay, so just to make it simple, because this is a mechanical problem, we have to open the valve basically, isn't it? So we have to open the orifice. So we do what we call as percutaneous balloon mitral commissurotomy, isn't it? So if it can be done by catheter based techniques, that is the best thing. If we cannot do it like that, we go for surgery also. Okay, in some cases what happens, there will be multivalvular lesions like mitral valve, mitral stenosis, regurgitation, aortic valve. In those cases also sometimes we go for surgery also, but as far as possible we go for catheter based treatment. Okay, so that is the basic treatment. But I think for you at currently starting your clinical exposure and all, I think more focus can be done in history and clinical examination. So you can ask me anything if you want, then I will go to the questions. Whatever questions you have, please, you can write those down. I will try to address them as far as possible. Do you have any questions that you want to ask me? Okay, so one other thing, so now looking back, do you feel like, okay, mitral stenosis does fit into the natural history of this patient or not?
Yes, sir.
So looking back at your history,
Yes, sir.
now our diagnosis, most likely our working diagnosis, provisional diagnosis, so that is basically mitral stenosis, isn't it?
Yes, sir.
So mitral stenosis, based on your history, now going back to your history, does the natural history of mitral stenosis fit into your history or not? Okay. Yeah, so now when you go to your first slide itself, or your history of presenting illness also, things make sense now, isn't it? So that's how it is supposed to be. Like at the beginning, you may not have thought that it could be so easily we could say that, okay, now this is most likely mitral stenosis, isn't it? So that's how we try to first make some differentials. Then based on our history, based on our examination findings, we try to rule those factors out. Okay, so those are the things. So should we go to the questions now?
Yes, sir. We can go to the questions.
Okay. So from whatever is available. Okay, so why joint pain is listed in past history? I think for rheumatic fever that can lead to RSD. Does it help to rule out any other differentials? Yes, in some cases of mitral stenosis, in cases of SLE also, or some connective tissue disorders also, there can be joint pain, isn't it? So maybe if we are not thinking rheumatic fever as the main cause of MS, then maybe those things can help. What is bowel and bladder habit? I'm not sure what this is. Okay, what is difference between atrial fibrillation and sinus tachycardia? Okay, so basically sinus tachycardia is like increased rate of the heart, which is more than 100. Atrial fibrillation basically is abnormal rhythm of the heart. It's a chaotic beating of the atria. So when we clinically, we can detect it as a regular pulse in sinus tachycardia, regular increased pulse rate. In atrial fibrillation, there will be irregular pulse rate, isn't it? And we can also detect a difference in the heart rate and pulse rate. That is called as pulse deficit. It will be more than 10 in cases of atrial fibrillation. All right. No history of syncope. So syncope in cardiovascular diseases can occur in aortic stenosis. So aortic stenosis initially, we also thought that could also lead to left-sided heart failure, but in this case, no other findings in the aortic area. So most likely aortic stenosis is not the main culprit in this patient, right? Can we say second degree heart block? Can I see the ECG?
Yes, sir. Just a minute, sir.
Yes.
Yes, sir.
Okay, lead to, where's the lead to? I can't find the continuous lead to, so it's pretty much short. Okay. Usually when we try to look for those things, we look in a continuous strip. Okay, so from this I'm not exactly able to tell you. Okay, I'm not sure there is second degree heart block looking at this. Okay, there were migratory joint pain absent, so it doesn't matter. like 1 out of 2 will not even give you a history. Okay, how can it be rheumatic in origin? Yes, absolutely. Usually, like whenever the valve is calcified, whenever the what to say that the distance between the cusps, whenever it's less, whenever it's severe, then the sound, the mitral valve makes a sound which is loud that we hear as S1. Okay, so excess of calcifications in clinical examination plus echo findings plus um, epidemiological findings, so all points towards rheumatic in origin, number one. Number two, we do not have any other systemic diseases clinically, like suppose in SLE also there can be mitral stenosis, but there are no other features of SLE in this patient, isn't it? So in our part of the world, with all that exposure and all those things, most likely rheumatic heart disease is the cause. Without prior history of RSD, can it be MSD? Yes, absolutely. We don't get actually history of RSD. As I told you, when we did echo in lots of school-going children, we did not find any history, but still in asymptomatic children, we did it, and then we found lots of cases of subclinical rheumatic heart disease. Okay, so that was found. Then which age group and gender is more risk for developing this valvular heart disease? That depends on the severity of the involvement. Okay, in actually endemic countries, the presentation is a little bit early. In not like in countries where the incidence is not so high, it can present a little bit later in the life also. Okay, then where to check for curly B lines? Okay, in x-rays you can find it. Curly B lines, basically the B stands for base. Okay, so at the bases we can find horizontal lines. Those are basically fluid in the septa caused because of the lung edema. Okay, so those things can cause curly B lines. So if present, it will be present at towards the basis of the lungs. Okay. How do we recognize opening snap? Yes. So opening snap, basically, one thing I'll mention is whenever mitral valve opens, usually it doesn't produce any sound. So whenever it produces sound, that's called as a snap. Okay, that's because of the opening of this calcified, immobile sort of mitral valve. Okay, so most likely because of that. So to know that this is opening snap, definitely you need to auscultate lots of patients. Okay, there's no hard and fast way to like tell you, okay, this is opening snap, but yes, because this is because of the opening of the mitral valve. Okay, so usually like it comes after S2. Okay, and basically the distance between those two sounds also can tell us about the severity of the disease. Can you explain about percutaneous balloon? Okay, so basically what we do is, I'll try to make it simple. We'll try to put a balloon inside the valve, which has been narrowed. Then we open the balloon. Okay, so we try to make the orifice bigger. Okay, so I think maybe it's a bit a too like simplified thing, but that's the thing. What happens, we put a catheter, then it goes to the left side of the heart. What we do is put the balloon is at the tip of the catheter. When the balloon is inside, deflated balloon is inside the mitral valve, we open that balloon so that cracks open kind of that calcified stenosed valve, and the opening is a little bit wide. Okay, and then immediately patients will start having improvement in symptoms even on the table itself. Okay, was mitral phases present in patient or not? Was it present in our patient?
No, sir.
No.
Malar
Okay. Okay, mitral phase is typically because of some people say because of the congestion in the upper part of the faces. So it used to be said, but I don't think these days we find lots of patients with this mitral phases. Okay, but if present, it's more like Malar flush kind of thing. Okay, maybe not present in our patient, isn't it?
Yes.
Pulmonary plethora, basically because of like increased blood flow to the lungs. Okay, so I think that's about it about the questions. So anything you want to ask, or should we conclude now?
I think there are no more questions, sir. So
Okay, then I think so. Let's go towards the conclusion now.
yes, sir.
सर म हजुरलाई एउटा क्वेसन सोध्छु सर.
Yeah, sure.
सर यो जुन चाहिँ नि लिड टूको चाहिँ जुन हामीले पी वेभमा हैन चाहिँ पी वेभमा पिक यहाँ एउटा देखिरहेको छ हैन, यदि चाहिँ पिक दुईटा त्यो बाइफिरेन्स पनि भन्छन् सर, त्यो त्यो देखिए त्यसलाई पनि चाहिँ देखेर एक्सक्लुड गर्न सकिन्छ नि आर्टियल फिब्रिलेसनलाई.
यस्तो छ हेर, अब if you get P waves in the ECG, that is not atrial fibrillation, okay? But biphasic, what you are trying to say is, actually each P wave, half is because of the right atrium, half is because of the left atrium. Okay, in mitral stenosis, first left atrium, then right atrium, both get enlarged. Okay, so you can get features of enlargement of both left as well as right atrial enlargement in cases of mitral stenosis. Okay, so you can see those waves, but if you detect P waves in the ECG, then it is, and then if you find features of LA and RA enlargement, those are suggestive of mitral stenosis. But if you do not find P waves, if you find irregular heart rate, if the rate is more than, like usually it's more than 100, then that is a case of atrial fibrillation. Okay, yeah.
Yes, sir. Conclude गर्दा हुन्छ.
Okay, then so I think a few take-home lessons. Cardinal features of cardiovascular system, we can say fatigue,
Yes, sir.
dyspnea, palpitations, and angina. Okay, so if we get any of these things in our patient, we can go towards cardiovascular system as one of our involved systems. Okay, other things, whenever there's a dyspnea, we have to think about respiratory and cardiovascular system involvement. Then other thing, whenever we make our differentials, first we'll try to include all the points if possible. Okay, so if possible, we'll try to include all our chief complaints and try to get to one single diagnosis. Like in this case, if we say mitral stenosis, it will include everything: difficulty breathing, palpitations, then this hemoptysis, whatever you wrote later, then swelling of the legs and all those things, right? But if we say anemia only, it can explain like a few things, but maybe not all things. If we say chronic obstructive pulmonary disease, we can say that a few things will match, but a few things won't. So first, we should try to include all the complaints that can fit into one criteria. After that, maybe 3 out of 4. After that, 2 out of 4. That's how we do our differentials. And then when we come to the examination, then we can rule them out one by one. Okay. And one very important thing is it's not always so easy to detect the lesions in clinical practice. Okay. Even after so many years of like listening to patients, examining patients also, these days also we do have difficulties like differentiating even AST and MS. So that's absolutely possible. Okay. So don't be disheartened if you cannot like detect what murmur this is, whether this is systolic. I can't find out this is systolic or this is diastolic. So don't worry about those things. Once you auscultate like 100, 200, 300 patients, then you will know, okay, now I get an idea of all these things. Okay, so keep on taking proper history. That is still, I think, one of the most important tools in medicine. Then try to do a proper physical examination. If you try to be like honest with your history taking and physical examination, then other things will definitely follow. Okay.
Okay, thank you, sir. Serena, continue.
Thank you so much, sir, for providing valuable insights on